Hi guys, welcome back to BROMED Lectures. In this video, we're going to cover hyperaldosteronism. Now let's begin with etiologies. For the most part, we're going to have primary with unilateral adrenal adenoma, better known as Cone syndrome, representing around 70% of the cases. And of course, next is going to be bilateral hyperplasia with around 30% of the cases. Now, secondary hyperaldosteronism is usually recognized as a compensatory reaction to low extracellular fluid volume that generates an upregulation of renin, and this is going to be the marker that is telling you that it is a normal response since it is not inhibiting renin, and it is due to the fact that you have a low extracellular fluid volume. Now, there's a similar mechanism with excessive black licorice. With this one, what you're doing is you're inhibiting the 11-beta hydroxysteroid dehydrogenase, which usually what it does, it inhibits cortisol to promote the activation of the aldosterone receptors. And so with inhibition of this enzyme, what you're doing is you're allowing cortisol to take part in the mineralocorticoid response for these patients, and so they develop an increased aldosterone-like response, and they can develop hyperaldosteronism syndrome. Now, for the clinical findings, of course, remember that aldosterone promotes sodium retention and potassium and hydrogen excretion, and so what you're going to see in these patients is, for the most part, hypertension, hypokalemia, development of alkalosis, and you may not see all the sodium retaining effects, and that is due to this effect, the aldosterone escape. In this one, the increased pressure is going to promote pressure natriuresis, and that helps the patient to get rid of some of the volume that they are accumulating. Now, the diagnosis, what you should do is to perform plasmatic aldosterone concentration to plasmatic renin activity. And it is positive if the ratio is more than 20:1. And of course, if your plasmatic aldosterone concentration is higher than 15, then you have your diagnosis, you have increased aldosterone with suppressed renin. And now the cheap way to perform your test is going to be to perform a sodium chloride challenge. In this one, you're overloading your patient and allowing for his adrenal glands to respond in regards to aldosterone. If there is a non-regulated mechanism of aldosterone secretion, you're going to see that the patient has no suppression of the plasmatic aldosterone concentration, and you may have your diagnosis. But of course, PAC-PRA ratio is going to be better. It's going to be more sensitive and specific for this condition. And now for the treatment, you perform imaging studies and other diagnostic studies to reach to the point where you are deciding if either you have an adenoma or you have bilateral hyperplasia. Now, if you have something resectable, such as an adenoma, a unilateral hyperplasia, carcinoma, etc., then you should remove with surgery, and the patient is going to do fine. But if you have bilateral hyperplasia, or if the patient is not suitable for surgery, what you do is you add spironolactone. Remember that this medication, what it does, it blocks aldosterone effects, and so you are providing your patient with medical management in this way.